So I just wanted to thank everyone for joining today. I hope you've been enjoying WAGO. My name is Dr. Catherine Fu. I'll be serving as the moderator for today's industry-sponsored supported symposium entitled Beyond ADCs, Exploring Novel Therapeutic Opportunities in Platinum-Resistant Ovarian Cancer. I'm honored to be here today with my esteemed colleagues, Dr. Dana Chase and Dr. Deborah Richardson. Please say hello and introduce yourself.
Hi, I'm Dana Chase. I'm a gynecologic oncologist at UCLA. I am the program director for our fellowship, and next year I'll be the program committee chair for the WAGO meeting, which will be in lovely Napa, California, so I hope to see you there, yay. And if you have any ideas or suggestions for the meeting, please come find me or email me. Thanks.
Hi, Debbie Richardson. I'm professor and section chief at Stevenson Cancer Center, Oklahoma, and was elected as a member of large to the WAGO Board of Directors today. So excited that you're all here, and I hope you enjoyed the talk.
So please see our disclosures here. All the relevant financial relationships listed for these individuals have been mitigated through our internal ACCME accreditation processes. However, if you perceive a bias during a session, please report the circumstances on the session evaluation form. This is an accredited program allowing you up to 1.25 hours of CME credits. In compliance with ACCME regulations, the GOG Foundation, as the accredited provider of this activity, must ensure that anyone in a position to control the content of the educational activity has disclosed all relevant financial relationships with any commercial interests. A designated official manages all reported conflicts to ensure a bias-free presentation. For those of you wanting to claim CME credit for this course, you must complete the post-test evaluation. You'll receive a post-meeting email with the link to the survey. The objectives of today's symposium will focus on the latest advancements in the treatment of advanced platinum-resistant, high-grade epithelial ovarian cancer. Ovarian cancer remains a significant challenge in oncology, particularly for heavily pretreated patients. This symposium aims to provide critical insights into the efficacy of new treatment options beyond ADCs. Okay, let's do a quick review of the agenda for today's symposium. The GOG Foundation would like to thank our commercial supporter, Corcept, for their support of this symposium. To stay on schedule, we'll be strictly enforcing the time limitations for our presentation. We really would like to have questions and answers towards the end, but also end at 1:30 promptly, so we'll do our best to get there. So now I'd like to welcome Dr. Dana Chase to discuss the evolving landscape of platinum-resistant ovarian cancer. Thank you, Dr. Chase.
Okay. All right, so I'm going to set an intention here. I learned that yesterday, so my intention here is to give you some hope for one of the most difficult patients that we see in our clinic as gynecologic oncologists. And for the trainees, I want to get you motivated to help us advance the science. So these are the landmark FDA approvals in ovarian cancer therapy. I realized, looking at this figure, that I'm as old as cisplatin. So cisplatin was FDA approved, I'm a little older actually, FDA approved in 1978, and then actually if you were a fellow up until 2014, it was pretty easy when you went to take your boards because you really didn't have to know too many drugs. Honestly, when I was a fellow, I really just had to know about pegylated liposomal doxorubicin. But then after 2011, everything sort of blew up, and actually in the last couple years, we've had two approvals and one hopefully pending approval for our most difficult to treat patient population, the platinum-resistant ovarian cancer patients. Now, before we get into how to treat these patients, I want to set the stage, especially for the trainees. These are some of the most difficult patients that we take care of. And in these patients, more than other patients potentially, there's three things we really go over with them. Of course, they want to extend their life, of course. And at this point, we can offer them 1.5 years, really, on average. But remember, at 6 months, 60% of these patients on treatment report substantial financial needs. Perhaps equally as important, if not more important for these patients, is improving their disease-related symptoms and managing their treatment-related symptoms. And these patients, more than other patients, perhaps have fatigue, worry, trouble sleeping, nausea, skin problems, hair loss, multiple others. And those symptoms that these patients feel correlate with poor quality of life. and quality of life in these patients is associated with survival. So this is really an area of unmet need. If you're a trainee and want to work on quality of life, this is a great patient population for this. And again, before we start to talk about therapy, I ask you to ask yourself, if you had 1.5 years to live, how would you want your life to look, or what would you want your life to be? So really that's an important and a crucial question here. So how do we define platinum-resistant ovarian cancer? Traditionally, it was based, we would say these patients are platinum-resistant, but what we really mean is how well will they respond to platinum at re-challenge. And it's interesting, the platinum-free interval of 5 to 12 months, the response rate of platinum is 27%. And as you get further away from your last platinum, that response rate goes up to as high as perhaps 60%. And so that's first-line platinum resistance, which is really, again, how you respond to platinum re-challenge. Now, what about secondary platinum resistance? Secondary platinum resistance is perhaps this potentially platinum-sensitive patient. You gave them platinum a second time, and then perhaps they are only just partially platinum sensitive at that point, and they are further defined by their response to platinum in the second line. So this is a great table that was actually presented at SGO this year originally. We do use platinum in platinum-resistant patients, and I will remind you that the ORR for platinum in these patients can be as high as 60%, and their PFS or their time to progression can be 6 months or higher. But Dr. Richardson reminded me that most of these studies are done before the introduction of PARP inhibitor therapy, which I think does introduce kind of a new level of platinum resistance in many of these PROC patients. So perhaps the new definition of PROC, or platinum-resistant ovarian cancer, is the bottom kind of bullet points there. Platinum-based therapy is no longer an option. That's what a PROC patient is. These are patients who have progressed while receiving platinum-based therapy or have experienced a symptomatic response, not a response based on CA125, not a response based on ctDNA, but a symptomatic response soon after the end of the last platinum, and perhaps platinum is now maybe a contraindication such as allergy. So that's platinum. Now let's move into some of the new agents that we've had approved in this patient population over the last really 5 to 10 years. This Aurelia trial was what I was learning when I recently finished fellowship. So this was what we were all excited about in 2011 to 2014, 2015. The addition of bevacizumab to standard of care single agent chemotherapy. And we were really excited because we got a PFS advantage. We went from a median PFS of 3 months in these patients to 6 months with the addition of bevacizumab. And the hazard ratio is 0.48. Unfortunately, that did not translate into a survival advantage. So we were excited, but we still didn't see these patients living longer. Many of these patients went on to get bevacizumab after the single agent chemotherapy, but we just didn't see a survival advantage. We saw that, perhaps the paclitaxel cohort maybe did a little better, although there's some bias there. But in my clinical situation, it's very difficult sometimes to talk a patient into losing her hair 3 months after her hair just started to grow back. So in my practice, it's hard for me to convince patients, even though that is maybe the most effective agent. What I thought was also, not just PFS, but what I also thought was interesting about Aurelia was this idea that we were actually improving gastrointestinal patient-reported symptoms. So this study, and we'll get into the Mirasol trial in a little bit, this study showed a benefit in terms of improving gastrointestinal side effects in patients on the Bev with the single agent chemo. Now there's been a paradigm shift. So if you're a trainee now, you really got to be up to date on these antibody drug conjugates. And these are kind of complex drugs in that there's 3 components of them. There's the payload, there's the linker, and the antibody. And perhaps, depending on who you talk to, one of those 3 components is the most important. And perhaps the combination is sort of like the magic there. And the mechanism of action is described as kind of a Trojan horse, meaning it tricks itself into getting into the cell and explodes the cell eventually because this cytotoxic agent is released. And mirvetuximab is now approved, FDA approved, to use in our ovarian cancer, platinum-resistant ovarian cancer patients that have a biomarker for it. And the cytotoxic agent is an anti-tubulin molecule. So keep that in mind in terms of that payload. The phase 3 trial was the Soraya trial. This trial, I just want to remind you, mandated bevacizumab use. So this is in patients that had previous bevacizumab, and the ORR was 34% versus 29%, and the median duration of response almost 7 months versus not reached. I'm sorry, it's investigator assessed and then BICR, not versus, but 6.9 months and then not reached in BICR, with a median PFS of 4 months or 5 months if you go by BICR. Now, once we saw these Soraya results, we started to realize that we're going to face symptoms that we haven't had experience with before, meaning these ocular toxicities. Most of these ocular toxicities are reversible, thankfully, but patients do experience them, and it can be challenging while patients are on therapy. And really, the ocular events and the neurotoxicity can result in dose delays or dose reductions. Less frequently discontinuations, but they are important. The Mirasol trial, this was also a phase 3 trial. This trial, the bevacizumab was optional, so you could or could not have had bevacizumab prior to enrollment. And on this trial, this is where we saw PFS advantage, and now we saw overall survival advantage with a hazard ratio for survival of 0.67, and that is a median PFS of 16 months versus 12 months. The ORR was 42.3% for the mirvetuximab arm. In Aurelia, the ORR was 27%. So we saw that really, that ORR improve in this mirvetuximab study. Now, the Mirasol Quality of Life, or PRO, this could be a whole hour of a lecture. If you're a trainee or if you're interested in PROs, read the paper, because there's a great discussion section about the PROs in this study, and they review PROs in other ovarian cancer trials. Unfortunately, they did not meet their primary endpoint for PROs, but there were exploratory endpoints that they looked at, such as fatigue, worsening physical and role functioning, that were impressive. So in this regimen, in the mirvetuximab regimen, we might not see an improved GI score as reported by the patient, but these patients did have less fatigue, less worsening physical and role functioning. And time to deterioration of quality of life really favored the Mirasol arm. Again, I'm going to refer you to this paper because it really is a good paper to read. Now, since mirvetuximab, many other antibody-drug conjugates are being developed or have been approved, such as trastuzumab deruxtecan and tisotumab vedotin in cervical cancer. And now I think many of us have these trials open at our centers that are targeting other proteins like TROP2, B7H4, cadherin-6, mesothelin. And this just will take me to the HER2 targeting ADC. On this study, the Destiny Pan-Tumor phase 2 trial included many different tumor types, but in the ovarian cohort, which was a little over 40 patients, 27.5% had an IHC score of 3+, and about half of the ovarian cancer patients were three prior lines or higher. In this study, if you see the ovarian cohort, the IHC 3+ response rate is 63%, 45% in the HER2 group. And then this translated for an IHC 3+ patient with a PFS of 12.5 months, median PFS 12.5 months, and then median OS is 20 months in the 3+ arm. So pretty impressive. If you can find a HER2 3+ ovarian cancer patient in your clinic, just show of hands, does anybody have those in their clinic? couple, maybe one. So it's hard to find these patients, but if you do, perhaps this is a great option for them. I just included this here. We don't really have time to go through all of it, but these are some of the other agents that are kind of in the works. Perhaps you have these open at your centers. And then finally, the GOG Partners phase 2 or 3 portfolio currently for PROC. Some of these are completed or discontinued, but we have GOG 3107, and then Dr. Fu is going to talk about GOG 3066 and 67. And then just finally, my personal sort of editorial on this, for future PROC trials, let's continue to try to show improvements in improvements in PROs and quality of life. Let's address financial hardship, target fatigue, work, sleep, nausea, and then let's try to extend the PFS beyond 6 months, and let's try to get these patients to live longer than a year and a half. Again, this is a difficult conversation with a patient when they ask you how long they're going to live, and you have to say, well, on average, a year and a half. It can be very difficult for us. So that's it for me. I'm going to turn it over now to my colleagues, and we'll have time for questions at the end, I suppose.
Thank you, Dr. Chase. Next, I'll be discussing beyond ADCs, novel agents and mechanisms on the horizon. And when we think about current strategies for platinum-resistant ovarian cancer, these are kind of the 4 major buckets. There's certainly more. ADCs, we've already heard a lot from Dr. Chase, so I'm going to focus on cell cycle regulation, immunotherapy of novel agents, and glucocorticoid receptor modulator. And even though these are in separate categories, there will be some overlap that you'll see, particularly with the glucocorticoid receptor modulator and how it may affect the immune system as well. When we think about cell cycle regulation, we've heard a lot about WEE1 inhibitors, talking about and aging ourselves. I remember enrolling a patient on a WEE1 inhibitor, davusertib, when I was a fellow. That was more than a decade ago. I actually am as old as cisplatin. And so when we think about the mechanism, though, for WEE1 inhibitors, we hear a lot about CCNE1, cell cycle checkpoint. So the 3 bullet points are just these foundational concepts for you to kind of look at and mull over. I'm really just going to focus on what azenosertib does, which is the WEE1 inhibitor. How does it work? It activates these checkpoints or cyclin-dependent kinases. It actually forces tumor cells into premature entry into mitosis. So then they can't really replicate well, so that increases replication stress, causes DNA damage, and cell death. So that's really how azenosertib and WEE1 inhibitors work and how they actually can combine with CCN1 amplification because they use a different checkpoint. So what are the trials that have been performed with these WEE1 inhibitors? So azenosertib with chemotherapy was presented as a poster by Joyce Liu in ASCO 2023. This is really just to show that they've done combination therapies before. But really the focus has really been on more monotherapy currently. This was presented by Fiona Simpkins at SGO this year, where she reported out on Denali, GOG 3066, a phase 2 trial, where really just confirming in all comers, so including CCNE1 amplified as well as those that are not, just the dosing and the safety and tolerability. And you can see that when you look at all comers, the objective response rate is about 20%, but if you really look at CCNE1 amplified, it comes up to about 35%. And this then led to the part 2A of this trial, which is ongoing right now and accruing, in terms of really focusing on patients with CCNE1 amplified tumors, and then you can see the 1-to-1 randomization of the dosing. And just to kind of show it's a 5 days on, 2 days off, and they've done a lot of this work in terms of intermittent dosing. This is what we'll hear more about this hopefully soon in the future. So this is just thinking about cell cycle regulation, what's going on right now. This is what's opened. The Mammoth trial, which is in PARP inhibitor resistance, has fully enrolled, so hopefully we'll hear more about that. So really now moving towards the next bucket, immunotherapy, immune checkpoint inhibitors. This is a table to really highlight. We've looked at first-line therapy, platinum-sensitive, platinum-resistant, and you can see the agents, the combinations, usually with chemotherapy, because we're really trying to do it in combination, and really just focus on meeting the endpoint, whether the endpoint was PFS, whether it's OS. You can see the X's really mean that they didn't really meet the endpoint. There are a couple of check marks. You can see with the first trial, which Dr. Richardson will touch upon later on, Keylink 001, and then Keynote B96, actually, which the data is pending. There was a press release out. But in general, no clinically meaningful activity immune checkpoint inhibitors presented thus far. There are a few that are still in the works that we'll hear more about, but that's sort of the takeaway point for immune checkpoint. So now what, right? We talk about ovarian cancer being maybe a cold tumor. There's some immunologists that I know in other meetings I've had that really will say it's actually a hot tumor, just needs to be warmed up somehow. So what are some ways to do that? Well, this is one approach that is currently had been developed and presented by Dave O'Malley in ESMO in 2022. And this is one idea, using a bispecific antibody. And what is a bispecific antibody? And really for the learners in the room, it's really taking an approach where you bring two targets together. So in this case, there's a cancer cell that's expressing MUC16, which is a gene that codes for CA125. And then really bringing together an activated, engaged T cell, a CD3 T cell that actually can help facilitate T cell activation and cytotoxicity. They've looked at these mouse experiments that show that there may be activity. When they ran the phase 1 trial, there was a durable response of 12 months. So currently this agent, there's no clinical trial currently, but just to show an example of another way to think about how to engage the immune system. So what are other ways? Well, actually looking at the glucocorticoid receptor signaling, this actually has been a way for tumor cells and immune cells to evade immunity. So we think about glucocorticoid as steroids. We give it to our patients when we give chemotherapy, especially paclitaxel, to really help prevent hypersensitivity reactions, as well as preventing nausea, give a little boost of energy. Have our patients call and say, I feel great after day 2 and day 3 of chemo. But what is the other aspect of steroid signaling, especially maybe when it's too much? So interestingly, glucocorticoids can exert an immunosuppressive effect, suppresses cytotoxic T cells, increases the M2 immunosuppressive macrophages. The tumors and your tumor-associated macrophages can actually induce this steroid biosynthesis. They're truly trying to evade the immune system. And so there have been work you can see here shown preclinically that these T cells do evade immunity, and they use this steroid pathway. We've seen that glucocorticoid receptor is abundantly expressed in ovarian cancer, and high expression is associated with poor outcome. So what is one agent to actually target this pathway? So, we're here, you will hear, is presented at ASCO, and we'll give some updates here too in terms of this glucocorticoid receptor antagonist, a selective one, so relacorilant. So this is a novel agent. And it has been found to restore sensitivity of cancers to cytotoxic chemotherapy. How does it work? Well, it actually binds to the glucocorticoid receptor with high affinity and prevents cortisol from exerting its effect. So you can see the yellow bubbles there are cortisol, and the teal are relacorilant. And so it really has this antagonist that's able to bind before cortisol can bind. And so it just acts as an antagonist. One thought is, and we'll show you this study, how it's combined with nab-paclitaxel, and you may be asking, why is that? And so for some of the learners in the room, the paclitaxel we usually will give with cortisol, and that can actually perhaps impair the efficacy of relacorilant. So this is the reason the nab-paclitaxel, it does not require steroid premedication, and that's the reason that it's been in combination. And so this phase 2 design, I like to show it because it really helps to show the thought process behind the phase 3 study trial design. And a lot of times when we're designing trials, as Dr. Richardson and Dr. Chase knows, we're thinking, is it intermittent, continuous, what's better? And so this really helped to answer that question. In particular, the intermittent dosing is a higher dosing at 150 milligrams, whereas continuous, you can see, is 100 milligrams. And so this one slide is chock full of information that basically the intermittent dosing did show, you can see the bottom red outline box there, that it was more effective than continuous dosing. Why is that? Maybe improved safety profile, restoring taxane chemosensitivity versus these effects of cortisol on the glucocorticoid receptor. Preclinical data suggesting a higher dose in the intermittent may actually enhance its effects. So this really led to the phase 3 trial. Dr. Richardson was the discussant at ASCO for this year, did a fabulous job. And so Rosella, phase 3 study, relacorilant in combination with nab-paclitaxel versus nab-paclitaxel monotherapy in platinum-resistant ovarian cancer, presented by Alex Alloway. And so who were included in this population? Platinum-resistant ovarian cancer patients, 1 to 3 prior lines, and prior bevacizumab is required. Dr. Chase talked a lot about some of our trials, which populations had prior bev, which ones did not. And this really makes a difference, as we are really, in this bev era where most of our patients will receive bev, so we really need to think about that as well as FDA approval. So here you can see the trial schema. It's 3 weeks on, 1 week off of nab-paclitaxel in combination with relacorilant the intermittent dosing versus nab-paclitaxel alone. Dual primary endpoints, PFS and OS. Dr. Richardson will also talk more about the stats behind that. So thank you, Dr. Richardson, for doing that. So I'll talk more about the study itself. So baseline characteristics were well balanced. You can see that there were in both groups actually platinum refractory. So these are our most difficult to treat. It's about 6% of patients. Prior lines of therapy. You can see that 100% had prior BEV. We also have about 60% that received PARP inhibitors, and then 99% had received taxanes sometime during their course. When we look at the PFS, here you can see, this is the exciting data, right? So you can see a median PFS improvement with a hazard ratio of 0.7, with a confidence interval of 0.54 to 0.91, with a p-value of 0.076, so meeting its primary endpoint. And so when you actually, patients will ask you, well, what's going to happen to me at 6 months, what's going to happen to me at 12 months, you can really see the difference there. And in particular, that teal arrow shows you at 2 months. You see that really breakaway point, right? The curves really do separate even at 2 months. So 6 months PFS, 52% with the correlate versus 42%, and then the 12-month PFS, you can see the difference really persists. And so this was positive and consistent, and we look at overall survival. This was an interim analysis. Maturity is about 50%. You can see that the median OS is 15.97 months versus 11 months, has a ratio of 0.69, p-value 0.0121. Dr. Richardson will go a little bit more in depth in terms of the statistics for this, but in general, there was this clinically meaningful improvement in overall survival at the interim analysis. And so you can see here at 12 months, 60% versus 49%. So then we always ask, what about the subgroups? We're really curious about that. Maybe this is only effective in certain subgroups. So let's go through this. So prior lines of therapy. So those who had two prior lines of therapy, you can see there was a benefit that favors relacorilant. In 3 prior lines, you can see a trend for that. Prior PARP inhibitors, for those who actually had prior PARP inhibitors, there was an improvement with relacorilant. And you can see in the BRCA1 and 2 mutations, we have so many of our patients where we're trying to figure out what do we do for those who may not really benefit from PARP inhibitor. You can see that those with negative or unknown BRCA1 or 2 mutations, they really did benefit and favored with relacorilant. Target lesions, if it's less than 5 centimeters, you can also see a favoring of relacorilant as well. And we looked at objective response rate, 36.9% versus 30%. And then you can kind of see also clinical benefit rate, 51% versus 38.9%. Many of us are saying to our patients, if we can get you to stable disease, that would actually be a win. And so this really highlights that this is a possibility as well with this combination. What about the safety, right? We have our patients that we know platinum-resistant ovarian cancer. This is a really big issue. We really want to make sure, as Dr. Chase has mentioned too, with patient-reported outcomes. So in general, you can see it's actually well-tolerated, favorable safety profile. When we think about and look at interruptions, you can see about 73% did have interruptions of the nab-paclitaxel and relacorilant due to treatment emergent adverse events, 54.7% in nab-paclitaxel. But in general, the discontinuations were there was really no difference really between the two. So really reassuring for our patients. If we want to dive a little bit deeper into the adverse events that you actually see from this agent, this combination, you can see that it's very, across the board, very typical for what we would expect with nab-paclitaxel. And if we want to hone in on the ones that might have higher frequency, such as neutropenia and anemia, you can see a little bit more of a difference in terms of the overall frequency and the actual grade 3. But if you actually look at the exposure-adjusted adverse events, so when you adjust for duration of exposure, you can see that really there's really comparable and no difference between the two. So in conclusion, when we think about this new agent that just got presented at ASCO and, what do we do with it? How do we, what are actually the take-home points? So relacorilant is first in class, oral, selective glucocorticoid receptor antagonist, extended PFS, and then it also compared to nab-paclitaxel. And the median survival, there was a clinically meaningful improvement in OS, and then it's well-tolerated safety profile, and, we should really, consider as a new standard for platinum-resistant ovarian cancer. And so, what's next for relacorilant? What other trials are ongoing? Bella trial is open. It's open at our site, actually. Dr. Alvarez will be happy. Shout out to our, I know others as well, too. And really looking at, thinking about this phase 2 combination. Again, platinum-resistant ovarian cancer in combination with bevacizumab. And in this trial, interestingly, patients could have bevacizumab prior as well too. So really trying to help us, think about what are other ways to even improve even more this combination. And we think about anti-androgenics and perhaps that combination with the glucocorticoid receptor. So hopefully we've been able to cover quickly. I know the current strategies that we have in platinum-resistant ovarian cancer, and have a really good idea that although they're in these separate categories, there really is their overlap as well too that we just described with perhaps the relacorilant affecting immunity as well, and immune suppression and really improving upon that. So with that, we're going to introduce Dr. Deb Richardson to now share digging into the data, making sense of PFS OS curves. Thank you, Dr. Richardson.
Thank you, Dr. Fu. I think I drew the short straw. Somehow I have to talk about stats, everybody's favorite topic. Okay, so I'm not going to bore you with too much, but I have to go into this a little bit to make sense of what we're going to talk about. So basically, I think you're probably familiar with at least two of these terms. You may not be as familiar with the third term, but these are measurements of treatment effects that are commonly discussed. Median survival time, you're all going to be familiar with that. So it's widely used, it's familiar to clinicians, researchers, and even patients know about these terms. It's clinically interpretable, and it's insensitive to outliers. But all of these things also have some limitations. So it's only one data time. And I'm going to show you some examples, not actually in GYN oncology, but in some other very big trials where this becomes really important, where the data can be presented in a way that kind of skews what is the true benefit. It's insensitive to both short and long-term survivors. It can have some wider confidence intervals, and it may never be reached, especially when data is presented at an interim analysis. And so we'll see some of that in some of the more recent trials that we're going to talk about. Hazard ratios, you're all going to be very familiar with this. Widely used, familiar to clinicians and researchers, but it's a relative measure. And it incorporates survival data from all patients, which is important. And it can be used in multivariable regression analysis, also important. But there's one really important thing that sometimes gets violated, and we don't really talk about this. It depends on the proportional hazards assumptions. And if you're doing a multivariate analysis, every variable included in that has to be proportional. If it's not, you've actually violated it and should not be using this method. And then there's restricted mean survival time. This is intuitive and clinically interpretable. It has no specific model assumptions, so it's basically always accurate. You can incorporate survival data from all patients, and it can also be represented as either an absolute or a relative measure. It allows evaluation of treatment benefits across various periods, and it also can be used in multivariate regression analysis. However, it's not widely used, and it requires determination of a cutoff time point. So interpreting the hazard ratio. This is more for the learners in the room than my experienced colleagues, but it's an instantaneous probability of experiencing the event of interest in the next time interval among individuals who have not yet experienced the event. And it does assume that the hazard ratio remains constant over time. So let's look at an example. OS has a ratio of 0.7. This is a 30% reduction in the rate, not the risk. And this is misspoken a lot at meetings, et cetera. Patients still progress. They just progress slower. Or in this case, it's overall survival. They still die. They just die at a slower rate. Censored. So this includes patients lost to follow-up or have not had the event of interest either at study conclusion or at the data cutoff that's being presented. Some will have the event of interest after the event of study or after the data cutoff, but some will actually never have the event of interest. And so this is just showing kind of three examples I pulled from GYN oncology. So at the top left is proportional hazard. The proportional hazards has been met, so the assumptions are correct and you can use this. Athena actually does this very well. If you look at any of these time points, whether it's 12, 24, 36, or 48, it is exactly the same, a 7% difference. That hazard is very stable. But, sorry, but Rosella actually in the overall survival does not meet proportional hazards for the first 6 months. They are right on top of each other. Then the curves separate, and interestingly, as time goes on, the curve separates more. So I'm going to be really interested to see when the overall survival gets mature, what does this look like? And then it would be really interesting to try and figure out why. What is happening at 6 months and why are they separating? And finally, the bottom, this is just a subset from Paolo. This was in low-risk BRCA mutation patients. Okay, it's just a small subset, but I did it to emphasize a point. You can see I circled some numbers. I had to bring my computer up here because I can't see that anymore. I'm sorry. Basically, by the last time point, there's only 2 patients at risk in the experimental group and 1 in the control arm. Okay, so you're trying to look at this, but the curves cross, right? Once that happens, it's not really reliable anymore. So what I'm trying to encourage you to do is you can't just read the abstract and look at the numbers. You need to look at the curves. You need to see how many patients are at risk. And you have to put the entire thing in perspective, including does the hazard ratio meet with what the benefit is being said for both the progression-free survival and OS as far as difference in months, et cetera. So now we're going to talk about some fun stuff, okay? I finally at least get to tell you about a trial. So I also distilled this at ASCO. This was presented by Dr. Hardy Bassard. And so this was the first trial to design. And just to remind you, this was patients who were adults greater than or equal to 18 years of age, and they had non-mucinous, high-grade, advanced epithelial ovarian cancer. Patients could have a primary debulking, interval debulking, or actually be inoperable, which is interesting. That's not often included in a lot of our trials. Originally, it started as a 3-arm trial. It was dropped to 2 arms. They dropped arm 1, which was the control arm, with maintenance of either bevacizumab or placebo, once PARP inhibitors were FDA approved. And that had been pre-planned, because when they were planning this, those trials had not read out. Once PARP inhibitor was approved, they dropped this arm. And so this included carbotaxol plus or minus bev, and then all patients got niraparib maintenance with or without dostarlimab. And there are multiple stratification factors that you can see on the right, including intended bev use, the HRR mutation status, so pay attention to that. Not all, when people do this, it's not always the same. So in this case, it was not HRD, it was HRR. And then disease burden. And so I know this is a really busy slide. I'm going to go through it. But first was the 4th trial that looked at upfront advanced ovarian cancer incorporating immunotherapy to our standard of care treatment. And as you can see, they vary in a lot of ways. So in Duo-O, the control arm was Bev. In Key-Link, it was placebo or Bev. Both Athena combo and FIRST had PARP inhibitor maintenance, and that matters. When we look at the experimental arm, both these varied whether it was the length of immunotherapy and also the length of PARP inhibitor maintenance. You'll notice that FIRST had the highest rate of neoadjuvant chemotherapy that was given. Whether or not BRCA mutated patients were eligible also varied. So some of these trials had no BRCA mutated patients. In Athena combo and FIRST, it was about 20%. How PD-L1 positivity, which we heard some nice presentations this morning, does that even matter in ovary cancer? Probably not, but how it was defined was different in these. So tumor area positivity or CPS score. And then finally, they had different stratification factors. But I'm going to point out something important. In 3 out of these 4 trials, no matter all these differences, immunotherapy addition added 1.4 months median progression-free survival. It's pretty standard. Now, I highlighted Athena combo. In fact, the immunotherapy arm in this group did worse than the PARP alone. You might ask yourself why, but the reason why is because the combination arm had more toxicity and patients had to come off either the anti-PD-1 or the PARP more often. Therefore, the PARP inhibitor arm did better because more patients on the PARP alone were able to maintain on it. And also, importantly, we can look at this median overall survival. There's no overall survival benefit to adding immunotherapy to frontline. So if you want my opinion of what I gave at ASCO, I think immunotherapy in frontline ovary cancer is dead, at least checkpoint inhibitors. So endpoints and statistical testing strategy. The primary endpoint was progression-free survival per RECIST by investigator assessment. So sometimes, most commonly, this is investigator assessment, but sometimes you'll see it's BICR, which is blinded independent central review. So they had a hierarchical testing strategy was used to control the type 1 error at the 2-sided 0.05, which is our most common p-value. And if the PFS results were statistically significant, testing would continue to OS. And also just to point out that patients with PD-L1 positive or HRD tumors and those with concurrent BEV were specified a priori as clinically plausible groups to have differentiated results. So the take home is that just because it's statistically significant does not mean it's clinically meaningful. And I think it's a call out when we're designing trials. What do we think is clinically meaningful? So yes, hazard ratio is 0.85. The confidence interval does not cross 1. I'm looking at this curve. I don't think it makes a big difference. I don't think as a patient is going to want to add immunotherapy to my upfront therapy. And if we look at 2-year progression-free survival rate, it's a 4% difference. If we look at 3-year, it's a 5% difference. This is just showing the PFS and the PD-L1 population, showing these curves are very similar to what we saw for the ITT population. The hazard ratio is almost the same. Whether or not they were PD-L1 positive did not predict response to the addition of the immunotherapy. Okay, so one of these trials is not like the others. Okay, DUO-O. Here we go. Bevacizumab as maintenance control, right? Compared to IO with a PARP inhibitor. That's the key. So yes, the hazard ratio was positive, 0.63, right? So we can look at Keeling. Again, Bev or placebo versus PARP with IO. Hazard ratio 0.71, but let's look on the right first. When we actually compare, when we do the right trial and have the right control arm, which was PARP in my opinion, our hazard ratio drops to 0.85, and really what it shows us is that the benefit is being driven by the PARP inhibitor, not by the addition of the immunotherapy. And there's just no overall survival benefit from the addition of IO to standard carbo-Taxol, plus or minus Bev, plus or minus PARP inhibitor. That's a mouthful. Okay, so this is the forest plot, right? I just put these in here, even though I was told to talk about PFS and OS, just to make a couple of little points. These are hypothesis generating. They're not hypothesis testing, despite the fact that sometimes the FDA has used some of these forest plots to decide who we can and can't treat with things. That's not what an intention to treat population does, okay? And it can introduce bias. So you can look at this and say, maybe patients with ECOG-1 benefit from the addition of immunotherapy. Maybe a planned interval debulking surgery would then say we should add immunotherapy. But the only way you can know that is to test that. This does not test it. It says maybe these are the groups that are going to benefit. If we look at this, you also have to ask yourself, does it make biologic sense? Make it make sense. So let's look at HRD unknown. Is there some reason why if the test doesn't work, those patients are going to benefit more from immunotherapy than all these other subgroups in HRD? I find that hard to believe. So remember, and lots of papers do this, but if you run 20 statistical tests in your paper, by definition, if you set your p-value at 0.05, one will be positive by chance alone, right? You've accepted a 5% false positive rate. Okay, so this is interesting, and this is what I kind of was hinting at the very beginning. This is 3 different examples out of the literature about skimming the median. So these are not in GYN. It doesn't matter what the trials are about. It's just going to make a point. So the top left is Checkmate 067. So if we look at this, this was reported as doubling the median overall survival from 36.9 months to 72 months. But let's really look closely. So what happens is these curves, the Kaplan-Meier curve, change over time, and they flatten out as the number of events really gets small. And so what happened is the ipilimumab arm with Nivo flattened out just above 50% for a long time before it crossed. And so let's look at 60%. If we go to 60% instead of 50%, there was a 5-month difference. Clearly, ipilimumab did not prolong the overall survival it did not double it, right? And look at the hazard ratio. It's not big enough. The hazard ratio is too little to say, you would expect a hazard ratio of about 0.5 if it's doubling the OS. So you have to look at the whole thing. Adriatic here on the middle, the same thing happens. Like if we had just had a few more events in the experimental arm compared to the control arm, it too would have dropped under 50%. Instead, it flattened out for 11 months before it drops under. Really, the benefit is more like 11 months. And if you look at 60% instead of 50%, it was a 9-month difference. And then the final one in this ESO-PEC kind of also shows it, same thing. It flattens out for a long time, whereas in the control arm, it flattened out after it crossed. But they both flattened. So in this case, what I'm trying to show you is that if the hazards aren't proportional and things flatten out at the median for a long time, 51, 52%, and then drop, that's probably not representative of the actual benefit. And so just to kind of bring it home, I had to go back to G1 oncology, okay, because that was some lung cancer stuff and esophageal. Rosella had a statistical plan for dual primary endpoints. And it's important that you kind of look at what were the statistics, how did they power their trial. So in this, they powered it for either one to hit. So yes, it was PFS or OS, but only one has to hit to be positive. If the p-value for either PFS, blinded independent central review, that's what BICR stands for, was alpha of 0.04, or the overall survival, they set the alpha at 0.01, is less than the respective pre-specified alpha boundary, the trial is positive. In this trial, it did meet its PFS BICR, therefore it was able to recycle their alpha. I'm not a statistician, I'm not gonna get into what that means, but the good news is they didn't spend it, and so now when the overall survival becomes mature, they will be able to test it at the p less than 0.05 mark. And so we're not supposed to do this, but I'm gonna kind of cross-trial compare anyway. I'm gonna break the law. So Mirasol, as we heard from Dr. Fu, is biomarker driven, Rosella is not. There's just a couple of points I wanted to make out. So the top is PFS, bottom is OS. And so for our progression-free survival, for Mirasol, right, again, it's a rate. So the rate was about 35% less in progression for patients who were folate receptor positive compared to control. And the OS was very similar, hazard ratio, 33% decrease in the rate of death in the mirvetuximab arm. If we look at Rosella, we had a similar hazard ratio, 0.7. It's about 30% reduction in the rate of progression. And then OS, not mature, but similar, 0.69. So these are very similar. So I think that gives us some confidence when your hazard ratio is very similar between your PFS and OS. And the other thing, and Dr. Fu kind of pointed this out a little bit, is if you see those errors on the PFS, what's really interesting is in that control arm, more patients in the control arm come off at the first disease assessment. So I do think that that's relevant, right? More patients are able to stay on, even if it's stable disease and they're not getting a response, they're staying on the experimental arm longer and they're able to stay on our standard of care arm. And with that, I'm going to hand it back. Thank you very much.
Great. Thank you so much, Dr. Richardson, Dr. Chase, for these wonderful presentations and sort of discussion points. Really wanted to have some time to answer questions. We do have cases to present, but we also really wanted to open up and see what questions. I see Dr. Cohen, you got to help me out. Perfect.
It's a great presentation. You guys crammed a lot, and that was a very high yield. So thank you for doing that. And I've had this conversation with many people already just in the last 2 days, but it's an exciting time, but it's a complex time. So sequencing. So based on this data, at this point, you see their platinum-resistant ovarian cancer patient in clinic next week, and maybe this is her first diagnosis. She progressed within 6 months of carbodoxil. How should we approach it? How would you approach it? What are we going to use first?
Well, at Oklahoma, they're going on clinical trial. If they're not eligible, then, obviously, hopefully, I've already done my NGS and my IHC, and I know what they're, are they biomarker positive or not? If they're biomarker positive, then I think at this point, mirvetuximab remains the only targeted agent that's, shown an OS benefit. I'm very reassured by the Rosella data, but that's not mature yet. So I think if I had a patient who was folate high today, I would be recommending MIRV first. If Rosella's OS is positive, I think at that point it becomes a conversation of there are two, treatment options, and kind of like we normally do. Go over the side effect profile and how often are they dosed, et cetera, and then it's a patient-physician discussion, shared decision-making.
I'm just going to play devil's advocate. Yeah. I believe in clinical trials too, but lately I've been having a hard time. Now we have these drugs that are more effective, right? And are the agents on the clinical trial as effective or better? Like if I find that HER2 3+ patient and it's her first platinum-resistant situation, I'm going to have a hard time putting her on a clinical trial versus trying her on TDXD. But I think now it's so complex because of these biomarkers that we're lucky to have, but there's going to be some patients that don't have the biomarkers, and those patients, yes, I think their only hope, is to improve on the Aurelia objective response rate of 27% and put them on a clinical trial that hopefully gets them above 30%, or perhaps other agents that might become available might be, that aren't biomarker restricted, might be a good option.
Go ahead.
As people are thinking more questions, please come to the mic. I'll sort of segue into another clinical scenario. Let's say this patient actually comes to you. from some other practice that, doesn't have any biomarkers at all. She's coming with you with ascites, just peritoneal carcinomatosis. She needs something. No biomarkers though. So what would you sort of recommend? How would you think through this?
The biomarker
She has no testing. Like she's just,
ascites.
ascites. She needs something.
Yeah, I mean, I think it's old at this point, but I know her gastrointestinal symptoms are likely to improve with paclitaxel bevacizumab. Now, the reality is, I have that conversation with her. I tell her paclitaxel is the most effective drug, or I think it's the most effective drug in this situation, and she says, no way, I am not going to lose my hair. Not even going to talk about it. And then I have to give her PLD Bev, and I feel a little bad about it because I'm not sure she's going to have a great duration of response. But I know with the Bev, I know likely her ascites is going to improve actually pretty quickly too, which I think patients, once they start to feel better, I think their quality of life improves. They can start to interact more with their family members, and I think that helps survival. So I think that's really clinically meaningful.
Yeah. How about you, Dr. Richardson?
I would agree. If I had Bella open, I'd want to put them on Bella, right? Because we just had relacorilant with nab-paclitaxel and add that Bev. So I would do that, or I would potentially consider, if I didn't have that trial open, but I had some other trial open, to your point, I mean, if I had a patient with HER2 3+, yes, I would put them on TDXD. That's just not that common in my experience with the high-grade serous ovary cancer. I see it a lot more with the other subtypes. But there are some ADCs coming with similar payload to TDXD that have really good response rates. So I 100% agree with what you said. I think ascites, does respond very well to Bev. But if they had a contraindication of Bev, et cetera, I'd be really looking at one of these drugs under development that has at least shown in some phase 1 data response rates up to 50%.
Yeah, I will say, just because of the learners and or the trainees, Bev can be scary. I mean, the minute the patient calls your office and says, I'm having abdominal pain, you think, you have a bowel perforation, you got to go to the ER. Mostly it's not that, but it can be very scary in these patients that have disease involving their bowel. So Aurelia is great, but it can be scary sometimes too.
Yeah. So thinking about other patient cases that say, their frontline treatment included chemo plus Bev, they have platinum sensitive, they had, maybe carbodoxil or carbopegylated liposomal doxorubicin, apologies. And then they become, their tumor comes and they have a hypersensitivity reaction, they can't get any more carbo. So based on, we've been talking about bevacizumab and prior use, based on all this data, what can they get with prior bevacizumab? Like, what have the trials really, focused on? So I think a lot of times we throw this out a lot, like prior bev use, okay, clinical trial, inclusion, exclusion. Like, so based on what you all just kind of trying to reinforce, what can be an option for those based on clinical trial data who've had prior bev?
I mean, mirvetuximab, nab-paclitaxel with relacorilant, both of those had patients with prior Bev. I also think you can use Bev after Bev. We have some data about that. So in this setting, I'd be very comfortable potentially continuing my Bev and adding a different agent, depending on what we're talking about, right?
Yeah, I agree. I agree too.
Yeah. And any questions out there? No other questions? Oh, please.
We were so clear. Nobody has any questions.
No, it's a shy audience today. But so for folate receptor, I think we all struggle now that we have a biomarker, and we've come full circle, right? At first, it wasn't active, but then we focused on the 75% or more, and it's positive. And now we're all seeing those patients that are 50% or 60%, or maybe 20%. We're lucky that we may have a folate receptor trial where we can get them on that trial. I know there's data about Bev plus obviously MERV. Where does that fit into your mix? So how low are you willing to go with your folate receptor score that you'll give them MERV plus Bev in this setting?
Yeah, I mean, I think it depends on the patient. I mean, I think if they're not a clinical trial candidate, and or if I or my neighboring sites don't have clinical trials available for that patient, I will consider her like an intermediate patient and try her on, if it's NCCN listed, the mirvetuximab Bev regimen. And just N of 1 experience, I have a patient that's been on that for a year, with stable disease, which Dr. Richardson reminded me that that's impactful as opposed to the patient that has a complete response and then progresses 6 months later. So she's had stable disease for a year on it. With intermediate staining, so I do offer it to some patients depending on the situation.
I agree. I mean, I think that's where sometimes some of the data, right, like the FDA is different than clinical practice, right? So some of my patients in phase 1 that have done the best are patients who have not gotten a response. They're stable disease. But when you can keep a patient on like 4th line or later on a phase 1 drug that's not, necessarily proven yet either for more than 12 months, which I have several of them, platinum-resistant ovary cancer, stable disease, they're always saying, well, I wish my disease was shrinking. Well, I wish it was too. But I would rather be that patient than the patient who gets a response at the first disease assessment. Maybe you confirm it, and then by the 3rd CT scan, you're taking them off for another, drug. So we don't capture that in duration of response, right?
I have a question for you.
Okay.
And I'm just curious, because you've taught me a lot with your presentation, and I think I get confused with what is more meaningful in maybe a phase 2 trial, for example, or even the phase 3s. Objective response rate, hazard ratio, or when they say median PFS. Like if you could do 1, 2, 3, most important to least when you evaluate a trial.
Hazard ratio is probably my number.
Hazard ratio, number 1.
Number 1 of the, well, I would like OS, but not all trials are powered for that, and so you have to keep that in mind. If that's a secondary endpoint, saying that there's not a difference in OS, that's a hypothesis generating. It's not a alpha spending test. So I look at how was the trial designed, what was their primary endpoint. But in general, I'm looking at hazard ratio, PFS, and also overall response. But it's not enough to have high response rate if it's not durable.
Makes sense.
Great, Dr. Cham.
There was some really interesting stuff at ASCO about PFS versus quality of life. And I'm curious if you guys have any thoughts on how we can kind of combine those endpoints more frequently
You're the
to
expert in that. I'm
really,
a quality of life expert.
yeah.
Yeah, I mean, the Q-TWIST analysis, which is, quality time without symptoms, progression, toxicity, that like a composite endpoint is an interesting one. But I don't think I've seen, at least in GYN-ONC, any trial that makes that their primary endpoint.
Right.
But I think in this patient population, it'd be really reasonable to do that. I think Dr. Bookman was talking about some of these, what's the term? These, is he here? The term of those trials, anyway, some of these trials that feasibility trials or anyway. Pragmatic trials that they could use Q-TWIST as one of their primary objectives, with some of these explorations of 1 year versus 2 year of IO or PARP inhibitor. It'd be interesting to have that, but.
I think that's where, like we had that call to action yesterday. This is where we need money in the NCI, right? Because drug companies, there's a lot of them in here. You can correct me if I'm wrong. But, they want their drug to be FDA approved. I don't know how the FDA would feel about using one of those endpoints as a primary endpoint in a platinum-resistant ovary cancer. Now, in pancreatic cancer, as a matter of fact, gemtaxetere got FDA approved in pancreatic cancer because it improved the quality of life of the patients, not for any of the things that we look at. So I think it's also disease-specific, but we don't have a whole host of data, historical data, et cetera. So I think first we need to get it. They did do a Q-TWIST in the Soraya data, actually. But I don't think we have a ton of that. And so that's where FDA has a lot to say about when these trials are being designed. These companies meet with the FDA. They have a meeting with them, and then they usually have like an end of phase 2 meeting with them to make sure that the trial is designed in a way that if it hits the way that the company is hoping it hits, and that we're all hoping, to have more options for our patients, that it's going to get FDA approved, right? So there's a lot of conversations that go on, and so when you guys are scratching your heads wondering why was the trial designed this way, or why are the inclusion exclusion like this, it has a lot to do with hoping that the drug is going to be successful and be FDA approved. Science experiments have to be done by the NCI. And when we're talking about pragmatic and stuff, that's usually not going to be funded by a industry. It's going to have to be funded, through cooperative groups or other mechanisms. And so that's like on us then to try and make sure that we preserve those dollars so we can run those trials that our patients need.
Yeah, I mean, that patient your group presented at Tumor Board, that was a great example of how quality of life or PROs are difficult when to manage sometimes, even though you want to keep the patient on the drug. And it's tricky. I think we do need to study that, and I agree that NRG is really important for that kind of question.
And do you guys think we should be measuring financial and time toxicity more? Like there was a gallbladder cancer study, I think, that showed the PFS was like 2.5 months, but they spent all of their time being in the study and taking, doing all the things they needed to do for the drug, whether it's like eye exams, et cetera. So I'm curious if you guys think we should be incorporating those endpoints too.
How many of you guys incorporate a financial toxicity screening in your patients?
We do.
Yeah, I mean, I was at NIEGO and the New England form of WAGO, and one of their team members presented a financial toxicity study that I found to be really important. And if there's a trainee that wanted to look at financial toxicity in the platinum-resistant ovarian cancer patient, at least 60% of them at 6 months are reporting significant financial issues. So that would be great to look at.
Sorry, just to piggyback on that, since we're talking about platinum-resistant ovarian cancer, and we have all these targeted agents and all these questions on sequencing and biomarker-driven and, biomarker naive. And does anyone use kind of the chemo ID data in like practice at all? Because that does have some more financially available options of some very easily and accessible chemotherapy regimens that have been shown to be, have a benefit for recurrence-free survival. So I don't know. I don't know if anyone uses that in their practice yet, or...
I haven't, but you're bringing up, Dr. Castellano, a really good point. Obviously that data was, I think it was presented by Dr. Herzog, was positive and did a better job of predicting response. But I personally have never used it other than we participate in the trial. Anybody in the crowd want to raise your hand if you've ever used chemo ID? Are you even familiar with what we're talking about? So there was a trial in PROC. I don't remember all this, thing, but basically it predicted, like you got biopsy or archival tissue. I can't remember if it was fresh biopsy or archival tissue, but anyway, half the patients just got investigator choice, and the other half got based on the results of the thing, and it did a much better job than investigator choice. And yeah, and also, in case you couldn't hear, it was like improvement of about 7 months in progression-free survival, I think. And I think some of it was even platinum resistant, but some of them predicted platinum, and so it did a better job of that. Now it did not include any of the new agents that we're talking about. This was all just standard chemo options. All right, well, you're not a very lively bunch. Maybe I put you to sleep for my stats talk, sorry.
Well, I think one, we talked about biomarkers, sort of maybe one concluding case, because I think, we kind of have in our mind sort of, our priorities and how we're going to sequence, but really just to really summarize, right? Like the biomarkers that we have available, HER2, folate receptor, there's subtleties in terms of the expression levels, high, medium, low, how we're going to prioritize sequencing, ADCs, non-ADCs, right? So I think we haven't really heard about actually side effects and how you would think about, bringing that into the mix, into the context. Like, how would you then, utilize, trying to balance that?
So I think there's a couple of things, Dr. Fu. Number one, I think we're going to have more than one ADC approved in the next couple of years, right? And so we're going to have questions about how to sequence these drugs. This is my prediction. We'll see if I'm right or not, but I suspect that patients will get 2 ADCs, and they will likely have different payloads. At least for now, that seems to be the number one mechanism of resistance to the ADC is the payload. So you'll get one topo-1 payload and one microtubule toxin type payload. And they will probably have different targets as well. You probably won't use the same target twice, but we'll see. We don't have that data yet. And then it comes down to talking to patients about toxicity. So, I heard people say they don't want first of all, I think paresthesia is a major problem with Taxol and the alopecia. On the other hand, when sometimes I talk to patients about mirvetuximab, they're like, thanks and no thanks. I don't want any ocular toxicity. Now, a lot of the newer ADCs don't seem to have ocular toxicity, but some of them have pneumonitis, and some of the tropes have mucositis, and so we have all these new side effects, and so it comes down to what patients can tolerate. And so, sometimes I feel like we present data a little bit unfairly, like, okay, yes, a grade 2 compared to a grade 3, 4, 5 is a lot better than, that. But grade 2 mucositis is like fairly terrible.
Yeah.
A grade 2 ocular toxicity means you probably can't drive, right? So that, to answer all the people who are bringing up the quality of life, things, those are important things, right? So how we look at it and how patients look at it is different, and I think that's where you have to engage the patient about what are the risks, and there are things we can do to mitigate some of these side effects, but we still don't even know how to prevent paresthesia. We can tell people to do X, Y, or Z, and it helps to some degree, but many patients do get these side effects, and so it comes down to dosing, like whether or not the patient's still working, what side effects are they willing to accept. That's my personal take.
Yeah, I mean, I think it can be challenging depending on the patient. I mean, you have to talk about hair loss, like you said, neuropathy. You have to talk, I wrote this down, ILD, ocular, and then hematologic toxicities can sometimes be really difficult to manage. And those 5, like each patient sort of has a different opinion about what's the worst. So it can be challenging. And I think it potentially spend a lot more time having to talk about toxicity than we used to.
Yeah, and I think fatigue is one too, that we kind of, but there's plenty of patients I know, I'm sure in your practice too, where they say, I'm just in bed for more than half the day, a few days after the infusion, and sort of really trying to fine tune which one of these novel agents may actually cause more fatigue in certain people, even though the clinical trials may say something differently, so.
I'll give you my my little cheat for fatigue is ginseng. If you guys aren't familiar with this, there's actually a JNCI paper on American ginseng. We have a paper in our clinic. You have to order it from Amazon. It has to be American ginseng. And they come in like 500 milligram capsules, and they take 2,000 milligrams a day. The only caveat is they cannot be on blood thinner because it increases their risk of bleeding. But actually, it's been shown in many patients to decrease their fatigue in cancer patients.
Great, thank you.
Great job with how efficient that was. You packed a lot of information into it not in the way that didn't was overtaxing. It was great. Thank you. Is there any data that you're aware of on whether or not there's a compounding effect of toxicities with multiple ADCs, whether in combination or sequential ADCs? I've been trying to find these data, and I really haven't had much luck, but is there any rationale to why this would or would not be the case? Like putting 2 ADCs together, are you going to see more ILD theoretically or not? Or
I'm not aware.
I know there's no data, but is there some rationale that my brain is not?
I'm not aware of any. What I would say is I think, I think we're all see that the more heavily pretreated our patients are, the more likely they are to have side effects. And it sometimes gets hard. Sometimes I tell patients, I'm not sure if this is the drug or your disease. And the only way I can know is to interrupt it. Do you feel better in a week or two? So sometimes I just interrupt it for a week or two and have them come back to clinic and see, are they feeling better? Are they not feeling better? But I don't think we know yet.
Yeah, sorry to interrupt. Some of the issues with the new ADCs that we now have available in trial, on clinical trial, the exclusion criteria includes prior treatment with certain ADCs. So those we're not going to have a lot of, until all of those become FDA available or FDA approved, we're not going to have a lot of that data, I don't think.
A couple things. So one, the HER2 story, I've had patients respond at 1+, and we've been lucky that we've been able to get the drug for them. So I'm curious, it's played out in the breast world, and I think where it's kind of being eked along by pharma to get to the 1+. I'm just curious what you guys are doing. If you have a 1+ and your limited options, will you try it? Trastuzumab deruxtecan. And then also, we haven't talked about Cytoxan, pembrolizumab, bevacizumab, but I've had some patients, same thing, where they've stayed on that drug, that regimen for a long time, well tolerated. Are you using that, and where do you use that, knowing it's different for every patient?
Yeah, great question. So I mostly have stuck to the 2+ or 3+. I think it was unfortunate that FDA did not approve it based on the data in after the Destiny pan-tumor in 2+, 3+. So I definitely use it there. Rarely have I used it in 1+ off of a trial. But we have ADCs that I can often put patients on. Now it's more commonly uterine than ovary that I have ADCs in the 1+ HER2 range. But I think that the topo 1 payload is really active. I think deruxtecan has really got a great bystander effect, and I don't think it's wrong, especially if you've utilized a lot of other options. And then, what was it? Cytoxin. Oh, yeah. So I do use that sometimes. We put so many, like I have, serial trial candidates, but for those patients who either decline further treatment or just like can't go on trial anymore, I think Cytoxin, Bev, Pembro is a great option, but it's something I usually use fairly late. I don't know what you guys do.
Yeah, I mean, I agree. Cytoxin, Bev, Pembro, the stable disease thing, I think is a real deal. I recently got burned with a HER2 2+ patient where she progressed on her 3-month scan and was symptomatic. And now she's not eligible for some of the ADC trials because she had topo 1 ADC. So then I felt like, oh gosh, I ruined her chance for some of these ADC trials because I gave her TDXD and now she progressed after 2 to 3 cycles. So I'm like, now I'm cautious about the 2+.
Well, maybe that's an argument for not giving the 3+ and do a trial first and then give the 3+ later.
Yeah, maybe. But anyway, every PFS I think is going to get shorter and shorter. But anyway, I don't have the best answer for that.
Yeah, I've treated a person with 1+, and they've had a nice response. So, yeah. Another question back?
Yep, sorry if this is a silly question, but I'm one of the trainees, so I feel like it's okay.
Perfect, please. Welcome.
Why does trial design require so many like prior lines? Like you have to get Bev, you can't have gotten an ADC. Like we have like 3 SBOs on our service now, and we're hesitant to give them Bev, and it feels like it excludes a lot of the patients.
So it'll depend on the trial. Some of the trials will say they had to have had prior Bev or be ineligible for Bev. So an SBO would make them ineligible, and so you can enroll. But that's an FDA requirement, right? So it has to come to prior lines. So really it was only 1 or 2 priors, but because it had a benefit, Bev is considered standard of care. So if you haven't seen Bev in the front line or the second line, you have to have a good reason not to have given it because they want to get FDA approved, and they have to show that at least the majority of their patients have been exposed to Bev. So it's an FDA regulatory issue.
Is that the same for like no prior ADCs?
Again, most of the trials will allow a prior ADC as long as it's not the same target, although some do in phase 1 because we're trying to figure that out, right? Like because some of the newer agents are more potent than our original ones, they have better bystander effects, and we still don't understand what the resistance mechanisms are. I mean, we could talk 30 minutes about what we know about that right now, but it's usually the payload. So once you've had a topo 1 payload, it would be very unusual for a trial to let a patient get a topo 1 payload, and it's unlikely to work. But there may be times when it would work, and that's what we need to figure out.
Thank you.
Great, thank you so much. So we are heading towards the end. So final reminder, this is an accredited program allowing up to 1.25 hours of CME credits in compliance with the ACCME regulations. Completion of the post-meeting evaluation result and distribution of your credits. CME credit certificates will, I'm trying to read this before you all leave, will be sent via email, but it's going to take 10 seconds. Within 5 weeks of completion, your feedback helps the GOG evaluate the success of our programs, develop content for future events. The session will be available on demand. Please go to www.gog.org for more details if you wish to access and watch this program again. So this concludes our symposium. The GOG Foundation would like to thank our commercial supporter, Corsup, for the support for the symposium, and thank you, Dr. Chase and Dr. Richardson. Fantastic job, and a big thank you to our audience for joining in this afternoon. Have a great day. Enjoy the rest of 2025 WAGO annual meeting. Enjoy your afternoon. Remember, buses begin to depart at 6 p.m. from the main lobby to our President's reception this evening at the Gardens of the Gods. Thank you for the
Thank
10
you, Dr.
seconds.
Fu.
Okay.